I'd like to talk with you today about the problem list, which is an important and underused feature of the electronic medical record. I'm giving this presentation from the standpoint of a provider who works at Lifespan. Specifically, I work at Rhode Island Hospital as a primary care physician. Hello, my name is Rahul Vanjani. I'm a primary care physician at the Center for Primary Care at Rhode Island Hospital. I'd like to talk to you today about the problem list. Let me start by saying that the problem list, that term in and of itself, is problematic. There are probably better ways of referring to a list that carries out these functions. We could call it medical list or past medical history. But in this case, I'll refer to it as problem list because that's what our electronic medical record, EPIC, refers to it as in the EMR. We're talking about the problem list today because it's an important and underused feature, especially here at Lifespan, for coordinating and improving quality of care for our patients. Here are some of the problems that we currently face with the way in which we use problem lists in our system here at Lifespan. The first is that there's no common approach. We all use the problem list in a variety of different ways. The second is that there's a lack of completeness, which means that there are often false negatives. The goal of a problem list is to ensure that every important medical problem is listed and expounded upon. And often, problem lists in our system might miss important diagnoses, thus there can be false negatives. There's also a lot of clutter in our problem lists. We, especially on the inpatient side, tend to add diagnoses to the problem list, and they're not always very relevant or appropriate for the problem list. That can cause clutter and render the problem list incomprehensible and unuseful. So how might we think about using the problem list? Prior to going into EPIC to demonstrate how I use the problem list, and there are a variety of ways of using it, I'll outline some basic principles. There are 4 types of conditions that we might consider including on the problem list. And hopefully this will serve as a helpful framework for you. The first are latent chronic diseases. someone might have heart failure with preserved or reduced ejection fraction that's been relatively stable. It's not necessarily landing them in the hospital. Their medication regimen has been the same for quite a long time. But you as a clinician know that this is an important diagnosis, regardless of how active it is. And so you're going to keep it active on that problem list. The second is multiple occurrences of transitive illnesses. The third are sequelae of problems. This one's interesting and I think open to interpretation. If someone has poorly controlled type 2 diabetes and it's progressed to the point where they have neuropathy, nephropathy, retinopathy, and perhaps the nephropathy has progressed to the point where they now have end-stage renal disease and are on dialysis, you might consider putting all of that information under the problem listed as type 2 diabetes, or you might consider expounding on type 2 diabetes under that problem, but then also adding an additional problem called end-stage renal disease, and then providing some specific information under that problem. And that's stylistic. Finally, undiagnosed long-term symptoms are a good idea to place on the problem list, especially if it's a situation where this person is encountering numerous providers or traveling across healthcare systems, especially within lifespan, and you think it's important that care be coordinated and there be a consistent message as to the workup that's been done thus far and what next steps entail. So let's enter into EPIC and take a look at our problem list. So here's the chart of a test patient. I'm going to click on the problem list. And here we have an example of a problem list that's been populated over the course of years. When I first begin to build a problem list for a patient in the outpatient setting, I'll often start from scratch because the goal in the outpatient setting is to do a thorough chart review and to then populate the problem list in a way that feels meaningful to me and to the providers with whom I work. And so I'll often go through the problem list, click on it to see if anyone has expounded on problems under the overview section. And if they haven't, and the problem seems relatively insignificant to me, then I will press resolve. And so what I'm going to do here is I'm going to go through and resolve each of these problems. I'm taking note of the problems, committing them to memory, and resolving. It looks like I can't resolve this last one. Now what I typically do is I begin a chart review, and we all have our own ways of performing a chart review. I'll just briefly review the way in which I do it, which is I try to read, if it's a new patient, I try to read every note in the chart. In the case of hospitalizations, I might just go to the discharge summary for that hospitalization. And if I'm seeing a patient for follow-up, I might just read every note from my last note. I'll then go through and review labs, imaging, procedures, cardiology. And as I'm going through these tabs, I will begin to learn about this patient's medical history. And the task in my mind is to, in parallel, begin populating a problem list that tells a story. A problem list wherein if this patient presents to the emergency department tomorrow, the emergency physician can look at my problem list and understand 99% of this patient's medical history, and thus very quickly contextualizing their very quickly be able to contextualize their chief complaint within their overall medical history. And so as I'm doing this chart review, I'll intermittently pop back into the problem list and start populating. So let's start with, I've read that this patient has heart failure with reduced ejection fraction. or actually even more specific, I read that they have heart failure with reduced ejection fraction, reviewed their echo and learned that their EF is 20%, and saw that the heart failure is due to ischemia. They've had stents placed in the past. So I'll be even more specific. I'll say that this person has ischemic cardiomyopathy to really try and capture as much as I can in that first line. And in the overview, I'm going to say diagnosed in 2018. He presented to RIH in 2018 with MI, status post PCI times 2 to DES plus RCA, repeat TTE in 2018 demonstrated EF 20%. I might expound on this further, or further expound on the results of the left heart cath. Repeat TTE in 9/2020 with an EF 40%, and whatever other findings were pertinent, except. Now you can see here there is information under this problem. And now I'll continue to chart review and add. We all have our own ways of thinking about our patient's medical problems. Typically I'll say diagnosed in and provide the date. I'll provide the most recent pertinent labs, hemoglobin A1C in 9/2020, 6.5%. I might also follow that up with the microalbumin, the creatinine, the LDL levels. And then I might want to create a space here for whether they're receiving appropriate specialist follow-up and when they last received it. Similarly, I know that this patient has cirrhosis due to alcohol use disorder. So I'll say long history of alcohol use disorder, see problem list for more information, resulting in cirrhosis with portal hypertension, managed by Dr. Kitty Chai of hepatology. And then I might say HCC screening, just to remind myself, Q6 months, done in 8/2020, next due in 2/2021, AFP, or in this case, I'll say EGD, and I'll fill that in. And then you'll note that here I referred to, under this problem of alcoholic cirrhosis, I referred to the problem of alcohol use disorder, but rather than elaborating on it there, my style is to then create a new problem called alcohol use disorder. And now I can talk about it here. And what's very nice, the problem list is particularly helpful when it comes to patients with substance use disorders and other diagnoses that can be particularly stigmatizing, because this is your opportunity now to create a narrative that lends itself to empathy on the part of nurses, providers, other staff at the hospital. He first began drinking at age 13. Both parents drank alcohol heavily. Father died when he was 5. He has consumed, 1 liter of vodka daily times 20 years, multiple bouts of withdrawal, including ICU admission, seizures, DTs. He was unable to tolerate naltrexone due to nausea, vomiting, currently maintained on Topamax, 50 milligrams BID, with reduction in drinking to, half a liter of vodka daily. Whatever other information you think. This has resulted in cirrhosis. See problem list for more information. So I'm referring back to the cirrhosis here. Now, the last thing I'll say is I personally also use a healthcare maintenance problem. This isn't the most elegant way to do this. The reason I do it is because, as you all know, the sort of epic features around healthcare maintenance, while the goal is for them to be proactive, they're not quite comprehensive. And so I have this standard that I use. It's not perfect, but and I update things as they come up. So now I have this problem list, and as I get information about this patient, for example, in my inbox, if I get a CC chart about this patient from their cardiologist, and if the cardiologist has made changes, or if the cardiologist notes that a new left heart cath was done and these were the findings, I will, in real time, as I'm reviewing that CC chart, open this patient's chart and update the part on ischemic cardiomyopathy. And what's wonderful about that is the goal here is to do little pieces and not to have to do these really extensive chart reviews before every appointment with the patient, or every time the patient is admitted to the hospital. And so if every time you receive a notification about the patient, you update the problem list in a way that feels relevant, then when it's time for you to see that patient in clinic or to see that patient in the hospital, your problem list is as up to date as it can possibly be. And perhaps you'll make some slight changes to it here or there, but all you have to do is review the problem list before you go into the room, and you have a pretty good sense of what's going on with this person, what you've done, what you need to follow up on. So one important piece of the problem list is, if we're going to use it as a system, it has to be visible to the rest of us. And a lot of people throughout our system don't necessarily click on this problem list tab. A lot of us live in this chart review area. And in the ED, for example, if a new patient comes in, the ED provider or other staff might click through notes to find clinically relevant information. And so it's important to have a progress note template that highlights your problem list. And so I want to just demonstrate for you what this routine follow-up template looks like. So when you open up a routine primary care follow-up template for this patient, what you see here is that this template includes the patient active problem list, which is distinct from the standard primary care follow-up template that we tend to use in our system, which really just includes the problems without the overview section. And so importantly, I recommend that you go in and adjust your template to include the patient active problem list as opposed to just the problem list. Because again, then when somebody is looking through your notes, not only do they see your most recent note, they also see the comprehensive history of this patient. And so I'll go back to Pages here to just type down for you how you might go into your current template and change out your problem list view. Instead of using your current problem list view, what you want to replace it with is the @ PROB overview notes at. And if you replace your current problem list section with this, you'll be able to create a note that looks like this. I highly recommend that you work on this, create your own style, and try to update it constantly. There's no question, based on meta-analyses and primary literature, that problem lists improve quality of care, improve coordination of care, and give us more time to focus on thinking about the patient's problems as opposed to having to do a chart review and really spend most of our time on that, trying to understand the patient. The chart review here is done, and what you have to do is just go back and look through things selectively, and that allows us to provide more thoughtful, higher quality care. Thanks for listening.